We're going to talk about hepatitis C, and this is part one. It's really just an introduction to hepatitis C, so it's a little bit of information about the whole broad spectrum of hepatitis C. I have nothing to disclose, and we're not going to talk about any off-label therapies. Today, the main objectives are going to be to identify at-risk populations and discuss treatment options for hepatitis C. So to start out, I'm going to talk about the epidemiology a little bit. And hepatitis C is the most common bloodborne infection in the United States. There's an estimated 2% of the population in the United States that has it, which is about 5.2 million people. About 40 to 70% of people may not even know that they have hepatitis C. Although I believe that number is probably going down now because we have better screening rates than we have historically. But mortality rates for people who have hepatitis C infection are actually about twice that of patients who do not have hepatitis C. Now here in Oklahoma, it's can be very, it's a common disease state that we see. And there are about 54,000 people in Oklahoma that are estimated to have hepatitis C chronic infection. And it's important to look at the progression of the disease. And so on the left side of the slide here, you can see that if a person gets infected with hepatitis C and they have a normal healthy liver, then over time, you're gonna see fibrosis, so the scarring of the liver because of the virus. I tell the patients it's like attacking your liver. And so over time, that scar tissue builds up, and about 20% of patients will actually develop cirrhosis over the course of about 20 years. And that's what the third column there is showing. And then of those, about 4% per year will develop hepatocellular carcinoma. So it's important to treat hepatitis C so that we can keep this from happening, so this progression of the liver disease. Hepatitis C associated liver disease is the #1 reason right now in the United States for liver transplants, and it's the #1 cause of hepatocellular carcinoma. Patients who have hepatitis C have a much higher healthcare utilization, hospitalization, and prescription cost. So if we can identify hepatitis C infections earlier, keep them from getting to that point of cirrhosis and hepatocellular carcinoma, we're going to save a lot in healthcare dollars. So this slide just kind of emphasizes that deaths due to hepatitis C in the United States actually outnumber deaths due to HIV. And actually it's all other reported infectious diseases combined. So the rate for deaths from hepatitis C is greater than everything combined that's reportable. The goal of treatment for hepatitis C then is to reduce all-cause mortality and reduce liver-related health adverse consequences. So we're talking a lot about end-stage liver disease and hepatocellular carcinoma. Identifying at-risk populations for hepatitis C. So it's a bloodborne infection, so you can think about all the things that might cause infection with hepatitis C in the blood. So those who inject or use intranasal drugs, so even one time when you're asking a patient, have you ever even used one time? People who have tattoos or piercings, especially those that are from an unregulated environment. So a friend or in prison is a big one. Prisoners in general or previously incarcerated persons are considered at risk. Children born to mothers who have a hepatitis C infection. The maternal transmission is really low, but it is recommended to screen children of hepatitis C mothers. Those who received blood products before 1992, and then people who have a hepatitis C infected sexual partner. Again, the rate for sexual transmission is low, but it's possible because if there's any blood involved, then there could be the transmission of hepatitis C. And then people who have an HIV infection are at a higher risk to contract hepatitis C as well. So having said all this, who to screen? And in the past, we've talked about screening, and it's really you would screen the baby boomer population and just those at risk. But recently, I think in about February or March of this year, the screening recommendations changed. And so AASLD, which is the American Association for the Study of Liver Disease, and the IDSA, Infection Disease Society of America, they write the hepatitis C guidelines. And their recommendation now is a one-time routine opt-out hepatitis C testing for everybody who's 18 years of age and older. And then they recommend repeat testing for anybody who has an increased risk for hepatitis C. So if you have somebody who screens negative, you would screen them again because of their routine risk for it. So patients who are on hemodialysis, anybody who's had a needle stick exposure or some kind of unregulated percutaneous exposure, like talking about tattoos. And then they recommend annually for people who inject drugs and HIV infected men who have unprotected sex with men. The USPSTF says that their recommendation is, instead of opt-out, it is opt-in screening. They want you to have that conversation with the patients about what does it mean to screen for this, why are we doing it, and what would the outcome possibly mean. And they're recommending everyone aged 18 to 79, including those who are pregnant. So if we're looking at the screening cascade here, basically you have the top, we're screening with a hepatitis C antibody. And that antibody will tell us if somebody has ever been exposed to hepatitis C. So it doesn't tell us if they have an active infection or not. So the hepatitis C antibody is a relatively inexpensive test. There are point of care tests for it or through your lab. And some labs may even have an antibody with a reflex to the viral load or the RNA quant. So that's something to look into at your facility. But let's say you get the hepatitis C antibody when you've screened a patient and it comes back non-reactive. So that means the patient has not been exposed recently or historically to hepatitis C. And at this point, you wouldn't need to do anything else unless the patient has those ongoing risk factors for acquiring hepatitis C that I talked about. So active IV drug use, hemodialysis, HIV infected men who have unprotected sex with men. So the patients who still have active risk factors would need to be rescreened appropriately. Now, if the antibody comes back as reactive, then it doesn't mean they have hepatitis C. It means they have been exposed to hepatitis C. And I think that language, to be like using that language with your patients, is important. And so that they can understand why you need to do follow-up tests. Excuse me. So at this point, you're going to get the HCV RNA or the RNA quant, viral load. There's lots of words you would use to talk about this, but that's actually what's going to tell us if the patient has an active infection or not. So I wanted to talk a little bit about what a viral load is. So the viral load basically is just how much virus is in the blood. And this is what we use to confirm an active infection, because sometimes patients, they say about 25% can spontaneously resolve the infection on their own. So they may not have ever been treated, but don't have an active infection. Our viral load may also help us define how long the treatment course is, and this is particularly true with sofosbuvir, ladipasvir, and genotype 1 patients. It also will tell us if the patient has been cured or not. So after they finish treatment, however long their treatment course is, then 12 weeks after finishing treatment, we get another viral load. And if it's not detectable, then that's when we can tell the patient that they have been cured from the hepatitis C. A viral load does not predict liver disease progression. And so a higher viral load isn't indicative of a more damaging case of hepatitis C. So back to our screening cascade. Let's say you got the positive antibody, and then you get an RNA or viral load, the quant, and it's not detected. So that's when we know the patient does not have a current hepatitis C infection. So either A, they've been treated and cured, or B, they resolve the infection on their own. And again, from this point, you may not need to do anything, especially for patients who don't have those active risk factors. Now, if they do have active risk factors for reacquiring hepatitis C, you don't go back to the antibody test, because a patient will always have a positive antibody once they've been exposed, and that doesn't go away. So if a patient is re-exposed or you have an active IV drug user, then you'll want to retest with the RNA quant or the viral load to tell if they have an active infection or not. Now, if it's detected, then that's when we know they have a current hepatitis C infection, and that's when you're going to link to care and go through the process for evaluating this patient for treatment. So things you need to know for workup: the genotype. So basically in the United States, we have 3 main genotypes, 1, 2, and 3. And there are medications now that are considered pangenotypic, which means you can treat all genotypes. So you may or may not technically need this, but I think for the purpose of especially starting out and working them up, it's good to know what their genotype is, and a lot of insurances still require that. The viral load that we talked about, hepatitis A serology. So basically, We just want to know if the patient needs vaccinated for hepatitis A or not. And then the hepatitis B serology. So this is important. So we can consider if the patient needs immunization, vaccination, or potentially they've had a natural infection with hepatitis B already, and we need to monitor for reactivation during hepatitis C treatment. CBC will tell us some things, right? We need the platelets to help us with liver fibrosis staging. The CMP, the same thing, the ALT, AST helps with that liver fibrosis staging. Bilirubin, albumin, those kinds of things to look at liver function in general. HIV status, because if they have a co-infection, then we'd want to start treating the HIV first. And also we can help, if we know both up front, then picking the right medications that will be easiest for the patient with the fewest interactions from the beginning. So if we're talking about treatment options, there are still several out there, but I'm just highlighting the most common ones, the ones that have the highest recommendation ratings from the guidelines. And so here, Harvoni, Epclusa, Vosavi, and Mavyret. And I just wanted to show like the different components of it to kind of help break it up for you. So Harvoni is an NS5B and an NS5A inhibitor. Epclusa is also an NS5B, but it has a different NS5A inhibitor. And then Vosavi, as you can see here, is basically Epclusa plus a third class, which is the NS3 protease inhibitor. And then Mavyret and Zepatier are both in the same categories of an NS5A plus a protease inhibitor. Here I showed which genotypes that they treat. And so you can see here, for genotype 1 patients, you can select any of the regimens and they'll be appropriate. There will still be some caveats on how you would do that, but they are potentially appropriate. And then conversely, Epclusa, Vosavi, and Mavyret treat all genotypes. And so then you wouldn't have to worry about that. There's still caveats in treatment duration and other considerations, but just in general. Now Vosavi, that middle one there, is actually reserved for treatment failures, just as a sidebar. I created this table to kind of help categorize things. So you can see here that I guess it's the second column, they're genotype specific medications. So Zepatier, which is the orange box, is only for genotypes 1 or 4, and it's 12 to 16 weeks of therapy, 1 tablet daily. If the patient is genotype 1A, which is the most common genotype, it will require a resistance test before you can use it alone without ribavirin. And so oftentimes we don't use Zepatier first line because of that, and would consider it if the other options aren't viable. The box below that, the green box, is Harvoni, and it's 8 to 12 weeks, again, 1 tablet daily, genotypes 1, 4, 5, or 6. Some considerations are that there are interactions with proton pump inhibitors, and I find that a lot of patients are on a proton pump inhibitor. It's also approved in pediatrics, and so genotype 1 pediatric patients who are at least 12 years old or 35 kilograms in weight can, and it is approved for them to take Harvoni if they have a hepatitis C infection. If we move to the top right blue box, Mavyret, now it's pangenotypic, right? So all genotypes 1 through 6, it could be, it's mostly an 8-week treatment regimen for all treatment naive patients. The one thing with it is it's 3 tablets every day with food. And so for some patients who maybe don't eat regular meals or even regular snacks, it may not be a good option. Other considerations with Mavyret, it comes in a pretty large box. So if you have a patient who may not have a consistent place that they stay, toting that box around may be difficult for them. And so just some things, social considerations to think about with that. It's not been studied with omeprazole doses greater than 40 milligrams, but 20 and 40 milligrams are okay with Mavyret. And it's also approved in pediatrics. So for patients who are 12 or older and then 45 kilograms can use Mavyret. The bottom right is Epclusa, and that one is 12 weeks. It's 1 pill once a day. And again, it has the PPI interactions like Harvoni, and it's not approved with doses greater than 20 milligrams of omeprazole. So that's something to think about. Now, if we're looking at the rows, really the difference here is the hepatic considerations. So the top row there with the Zepatier and Mavorette, you know, they're contraindicated in patients who have child P or B or C decompensated cirrhosis, but they can be used in all stages of renal disease. The bottom row, the same thing. They now can be used in all stages of renal disease. So if you haven't looked at hepatitis medications in a while, this might be new information for you, because in the past, Harvoni and Epclusa were not approved for GFR grade or less than 30 or for patients on dialysis. However, now we can use that, so that's been really great. And they can be used in all levels of cirrhosis, like even decompensated cirrhosis. So I know that's a lot of information, but that's why I try to put it in a table, hopefully to kind of give some visuals and help you reflect back on that later if you wanted to look at it. Now this is for treatment naive first-line therapies, are the only ones that I looked at for this. So I talked a little bit about drug interactions, and really it's going to be very important that you do a drug interaction check before selecting a medication. So you can use LexiComp. I would use a paid drug interaction checker such as that, or the University of Liverpool has a hepatitis C specific drug interaction checker, and I put the website there for that. And I really like it because it specifically looks at interactions between the hepatitis C medications and their list. It doesn't do an interaction check between the non-hepatitis C medications, if that makes sense. So if a patient's on 20 medications and you put them into a regular drug interaction checker, not only are you going to see potential interactions with the hepatitis C medications, but you're going to have to like filter through all the ones between their heart failure medicine and their hypertension medicine and stomach medicines and all those things. And so it might be harder to specifically focus on those hepatitis C interactions. Where here, the report will only show you interactions between the hepatitis C medications and the patient's medications. And it's really up to date. So they update it very often as new information comes out. So in conclusion, just wanted to say, you know, treating and curing hepatitis C can decrease the incidence of cirrhosis and hepatocellular carcinoma. It's important to offer screening to everybody who's at least 18 years of age. Repeat that testing as needed for patients who are still at high risk. And it doesn't take a specialist to treat hepatitis C anymore. So if you are interested in treating hepatitis C, you know, we're here to help you. There's a lot of treatment options that are available, and you can present the case here, and there is no case that's too simple or too complicated. We also have a hepatitis C echo on Thursdays as well. And I think, you know, either one of these echoes, it's appropriate to present a hepatitis C case, and we can help walk you through it, and we'll all learn something together with each new case that's presented. Okay, so that is the end of our presentation. I can take questions if anybody has questions right now.